Imagine this. A patient suddenly gasps for air, clutching their chest. This could be a pneumothorax, what most people call a collapsed lung. Today, we're going to break down this really critical condition, from the subtle signs all the way to the life-saving things every single clinician has to know.
So what exactly is a pneumothorax? Well, as you can see, it's all about air getting into the pleural space. That's the little area between your lung and your chest wall. Normally, that space has negative pressure, kind of like a vacuum seal that keeps the lung pulled open. But when air gets in, that seal is broken, and the lung just naturally springs back on itself, causing a partial or sometimes a complete collapse. Now, a regular pneumothorax is serious, for sure, but things get truly dangerous when a one-way valve situation develops. What does that mean? It means with every breath the patient takes, air gets into that pleural space, but it can't get out. And as that air just keeps building up, it creates this insane amount of pressure inside the chest. That is what we call a tension pneumothorax. And let me just say this again because it's so important. A tension pneumothorax is a life-threatening emergency. That rising pressure doesn't just squash the lung, oh no. It starts to compress the heart and the major blood vessels, making it almost impossible for them to pump blood. This can cause a total cardiovascular collapse, and fast. Okay, so now that we get just how serious this can be, let's look at the different ways it can happen. It's really key to understand the context, because not all collapsed lungs are the same. There are 4 main types, and each one has its own cause and, a typical patient you'd see it in. This table lays it out pretty clearly. First, you've got primary spontaneous. This is the one you see in young, tall, thin people who are otherwise perfectly healthy. Then there's secondary spontaneous, which happens because of an underlying lung disease like COPD or asthma. Traumatic is exactly what it sounds like. It's from an injury. And finally, there's tension, the really bad one, which is all about that one-way valve mechanism we talked about. Knowing these categories is your first step to getting the diagnosis and treatment right. All right, we've gone over the types, so now let's get into the clinical signs. Your ability to spot these signs quickly is absolutely crucial, especially when you might be looking at a life or death situation.
So let's put ourselves in the room. A patient comes into the ER, they're suddenly short of breath, and they have chest pain. What are the specific signs that should make a light bulb go off in your head and make you think this could be a pneumothorax?
The classic textbook presentation is a sudden, sharp, pleuritic chest pain. That's pain that gets worse when you breathe in. And of course, shortness of breath. When you examine them, you'll see one side of their chest isn't moving as much as the other. If you tap on that side, a technique called percussion, it might sound really hollow and drum-like. That's called hyperresonance. And when you listen with a stethoscope, the breath sounds will be really quiet, or maybe even gone completely. Those are your core clues right there.
Okay, but while those are the classic signs for a simple pneumothorax, a tension pneumothorax is a whole different beast. The clinical picture is way more dramatic, way more scary, and it's basically shouting that the whole system is about to collapse.
This slide shows you the absolute drop-everything red flags. The pressure inside the chest can get so high that it literally pushes the windpipe, the trachea, over to the other side. That's a massive finding. You'll also see the heart is starting to fail. The patient's blood pressure will be dropping. Their neck veins might be bulging and their heart will be racing, just trying to keep up. When you see these signs, you are in a race against the clock. So, once you suspect a pneumothorax, what's next? You need a clear plan of action, moving from how you confirm it to what you actually do about it. A chest X-ray is usually your first stop. You're looking for that classic thin white line, the edge of the collapsed lung, with no lung markings outside of it. In a trauma situation, a quick bedside ultrasound can be a game changer. You're looking for something called absent lung sliding. A CT scan gives you the best pictures, but it's usually saved for cases that are tricky or keep happening. And here it is. This might be the single most important rule of this entire explainer. If you clinically suspect a tension pneumothorax, if you see those red flag signs, you do not wait for an X-ray. You treat immediately. Waiting for a picture could be a fatal delay. This is a clinical diagnosis first and foremost. So how do we manage it? Well, it really depends on how big the collapse is and how stable the patient is. For small, stable ones, you might just give them some high-flow oxygen and watch them carefully. But for larger collapses, or if the patient is really struggling to breathe, you have to be more aggressive with things like needle aspiration or putting in a proper chest drain to get that air out. Now, for a tension pneumothorax, the management is an immediate, life-saving procedure. Step 1, without a doubt, is needle decompression. You take a big needle and you insert it into the second intercostal space in the midclavicular line. You'll often hear this incredible hiss as all that trapped air rushes out.
That sound instantly turns a deadly tension pneumothorax into a much more manageable, simple one, and it buys you the precious time you need to then put in a definitive chest tube.
Okay, we've covered a ton of ground, so let's wrap up by boiling this all down to the key takeaways. These are the high-yield facts you absolutely need to have locked in, both for your exams and for your actual clinical practice.
The next couple of slides are all about pattern recognition. Getting these key associations down is what helps you make a super fast and accurate diagnosis when it really counts.
Exam pearl number 1. If your exam reveals hyperresonance when you tap on the chest and you hear no breath sounds on that side, your brain should immediately scream pneumothorax. That's the classic 1-2 punch.
Exam pearl number 2. Now, if you find those same signs, but you also see that the trachea is shifted and the patient's blood pressure is in the tank, you have to immediately think tension pneumothorax. Those are the alarm bells for an urgent, life-saving intervention.
And finally, exam pearl number 3. In any trauma patient who suddenly can't breathe, your number one priority is to treat, not to investigate. You have to assume it's a tension pneumothorax and act on that suspicion right away. Treat first.
So let's finish with a question to get you thinking. You're there, it's a real-life trauma call, and your patient is in severe respiratory distress. Based on everything we just went over, what's the one physical sign you would check for first to tell you if this is a simple collapse or a tension pneumothorax? Answering that question correctly could literally save someone's life one day.